Good afternoon, distinguished officer, enlisted person, honored guests, and fellow students. It's an honor to be here today in the presence of those who exemplify leadership, dedication, and selfless service to their countries. My name is Student Sergeant Anghel Liviu-Florin. I'm a third-year student at the Medical Military Institute of Bucharest. And it's the first time I present in front of such a distinguished audience, and I wanted to thank to the organization committee of TMAF for letting me be present here. What we're talking about today is not just strategy, it's about ensuring the safety and readiness of our troops in the most critical moments. So today I will present the level of our training impact that the advancements in military medical doctrine brought to the battlefield. I'm going to start with the objectives of my paper. Firstly, I started with the statistics of wounded in action survival rates before and after the introduction of TCCC, of Tactical Combat Casualty Care, and the medical treatment facility protocols over the years of a conflict. In the second part, I will present the Tactical Combat Casualty Care protocols with general aspects. And in the third part, the rank of level role, medical treatment facilities, also the general aspects. So I'm going to start with presenting the statistics of the American conflicts. In the World War II, they had a case fatality rate of wounded in action personnel of 19.1%. After that, they started developing tactical casualty combat care protocols, and it lowered to 15.8%. Going so, in the 2001, in Operation Enduring Freedom and during Operation Iraqi Freedom, because of the introduction of tactical combat casualty care protocols and medical treatment facility protocols, with bringing the forward surgical team as close to the front line as possible, we can see the decrease in the fatality rate plummeting to 9.4%, which was a pivotal moment in the medical doctrine evolution. Also, we're going to start with presenting the tactical combat casualty care stages. The first stage is care under fire, the second one is tactical field care, and the third one is the tactical evacuation care. In care under fire, the key points of this part are the first safe aid, the body system, the importance of the combat lifesaver, and to suppress enemy fire so we can secure the perimeter, so we can move to a secure position and stabilize the wounded personnel. Going so, when we don't have a combat lifesaver present or it can't get to the victim, to the wounded, we've got the first self-aid and the body system that we are familiarized with in basic training when we need to take care of our fellow teammate. So before going in operations, we'll be conducted to know how to give BLS to him, basic life support skills, how to place a tourniquet, and the most important part, how to self-administer the tourniquet, how to self-put it on you. So we will have the plummeting of the fatality rate of the hemorrhage extremity wounds. Going on about the combat lifesaver. The combat lifesaver, the first thing that he does, like I said, is the hasty tourniquet. Because after statistics conducted by the Americans, we have a fatality rate drop of 85% caused by extremity hemorrhages during war because of the introduction of this piece of equipment, which was one of the most important parts in our doctrine evolution. The second part is the fact that the combat lifesaver, it has the opportunity, after securing the perimeter, he can assess the wounded in action patient, so it can say to the combat medic that will come in the tactical field care part exactly what he will be dealing with. So using the MARCH algorithm, we have the massive bleeding, the airway control, the respiratory support, the circulation, and the hypothermia prevention, which are the 5 key points of assessing the victim during care under fire and also under tactical field care. Going on the tactical field care, we will have the combat lifesaver that came with the troops, with the wounded, and we will have a combat medic that will join him in treating and stabilizing the patient so he can be evacuated or re-enter the fighting grounds. In this part, although direct fire has ended, it can start again at any time. So the CLS will try with the combat medic to immobilize fractures, to stop bleeding, to control the bleeding, because after putting the first tourniquet, after some time we need to put the second to apply a second tourniquet, because if we leave the tourniquet on for a long period of time, it will do great damage to the tissue at that level. So we will apply a second tourniquet higher from where we applied the first, and just take the first one out, so we can ensure that the bleeding has been stopped and that we don't further cause much more damage to the wounded. Here, because of the penetrating wounds, we will administer large spectrum antibiotics, and we'll have the part of shock management, the psychological BLS, where we can talk with the shocked troop so we can help him realize where he is in that moment, so he can do what he can follow the orders and not just remain in shock and be a lost person there. After the patients are stable, the combat medic will fill the tactical combat casualty card, so when he will be evacuated, when he will reach the medical treatment facility, the doctors that will take care of him there will know exactly what happened, what has been administered to him, what type of wounds that he have, and everything that comes with. Right here, I will show you the part that a combat medic can do here. We've got the air management, we've got the needle decompression, where here we can see that to decompress the lungs, so in cases of pneumothorax, the needle decompression will be made in order as such. The syringe will be introduced at the top of the third rib and in the second intercostal space. So, because the nerves and the blood perfusion is at the bottom of every rib. So that's why we need to introduce it at the top of the rib, so we don't cause damage to the nerves and to the blood perfusion at that level. More so, if we've got buccal damage, if we've got a problem there, a constriction at that level, we'll introduce an airway insertion through the nose, to the nostrils, so the wounded can breathe correctly. Furthermore, in the airway management, we had the chest seal, because in case of pneumothorax, it could be massive bleeding, it could be air decompression. So the chest seal will prevent this and will block the wound, will seal it, and will let blood to come out and air to come out, but it won't let anything in. That's why it's called a chest seal. Going furthermore, this is the tactical combat casualty card that we talked about. The combat medic will fill for the doctors at the medical treatment facility to know exactly what happened. Here we've got the isothermal foil that is used to prevent hypothermia in cases of hemorrhages and to help accommodate the hyperthermia in burns victim. And here we've got a trauma bandage that is a good tool for everything, like to immobilize fractures, to seal penetrating wounds caused by bullets, and all this all that come with. Furthermore, in this stage of tactical combat casualty care, we've got the part of Medevac and Casualty request. The methane protocol, where we need to communicate with the base the military details, the exact location of the incident, the time and types of incident, the hazards in the area, the approach routes for vehicles and details for the rotating wing landing zone, number, nationality, and type of casualty, and the expected response. Using codes like I tried to exemplify here, taking them from the NATO protocols of evacuation. Here we've got the location, the grid coordinates, the call sign, the frequency that we will talk on, the packs by precedence, where we see the number of patients and the precedence, what exactly happened there. We will need to say if the wounded in action are in urgent need of medical care or in urgent need of surgical care. We'll see about the priority. Priority means that it could be evacuated in 4 hours, not 2 like the urgents. And the routine will be that can come back in the fight, can be evacuated in 24 hours, and doesn't need urgent treatment. Going so, we'll get the special equipment, because when we will call for the Medevac to come, we need to say exactly what the medic that will come with the Medevac needs to have at him so he can stabilize the patient, so he can support the transportation from the battle zone to the medical treatment facility. More so, we'll talk about the security of the pickup site. We'll say N for no enemy troops, P for possible enemy, E for enemy in the area, proceed with caution, and X for enemy in the area where we will need armed escort to facilitate the evacuation. More so, we'll have the pickup site mark, because we'll need to say we've got panels, we've got pyrotechnic signals, we've got smoke signals, we've got none or other. Furthermore, we'll go to the third stage, the tactical evacuation care. Some mentions here will be that the wounded personnel will be transported to the medical treatment facility, depending on the assessment that the combat medic made in the field. He will go to a role 1, role 2, role 3, or role 4 medical treatment facility, which we'll talk about in a second, in the second part of the presentation. Here, if we will use a Medevac, which means a vehicle or an aircraft that doesn't have medical treatment facilities, capabilities equipped on it, the combat medic will go and assist in the evacuation of the wounded personnel. Like I said, here we've got the 2 main evac vehicles. We've got the Medevac, where is neither the vehicle nor the aircraft used for a Medevac mission is purpose-built for medical transportation, and the Medevac, which are vehicles and aircraft that are equipped with medical equipment and typically have a doctor on them. We've got some examples of how the 2 evacuation transportation units look like. Here we can see the difference, the medical equipment in the Medevac and the simple style of the Casualty. Further so, in the last years, we encountered at military expositions these 2 types of new Casualty equipment, which are remotely controlled and will ensure a faster way and a more secure way of transporting victims out of the tactical field, because here we won't put at risk the personnel that will come with the transportation unit. And being remotely controlled, we can have it faster. Okay. Here I've got the resume of everything that I've talked till this point. If anyone has any question or comment in the first chapter of the presentation, please. Thank you. Right now we'll go to the second chapter, the medical treatment facilities. We're going to talk about role 1, role 2, and role 3. The accolade there is made because they are still in the tactical field, and the role 4 will be the military or civilian hospital outside of the combat zone. Going more, here we've got an example of role 1 planification scheme. Here we can see the primary medical assistant units, the priority 1, priority 2, the triage part in the middle where everybody will come in, the priority 3, which are not emergencies, are just personnel that will get out fast. And in T4, we have the places where we can bring another modules, units from other types of role. Like if we will have an augmented role 1 MTF facility, here in the T4 square, we will have the forward surgical team module and the intensive care unit module. Like I said, depending on the strategic placement of the operation, and if required, we can augment the role 1 facilities. The forward surgical team has damage control capabilities that mean fixating external fractures, temporary and definitive hemostasis, wound sutures, stabilization of pelvic bone, cricothyroidotomy, and pulmonary decompression and limb attachment surgery, temporary limb attachment surgery. Because here in the FST module, we don't speak about definitive surgery. We speak only about emergency, temporary stabilization surgery. So here the life-saving in the front is done, so we can evacuate the victims to a more equipped treatment facility. Here are some wounds that can be treated by a forward surgical team. Here we can see the external fractures here and here. There we've got an example of the limb attachment wounds, the wounds that need temporary limb attachment for stabilization. And here we got again an external fracture. And there we've got a penetrating wound made by a foreign object. At this level, at the forward surgical team level, we can do, and this part, the part of removing objects from our soldiers, because it enters the emergency surgery part. Going on, we're going to be to the Role 2B and Role 2E medical treatment facilities. Role 2B, we've got the forward surgical team, the intensive care module, the temporary limb attachment surgery because it enters the capabilities of the forward surgical team. Here we've got more an emergency module, a paraclinical investigation module, a patient stationing, a postoperative care, administrative, and medical logistics. Going so, the Role 2E stands for Role 2 Enhanced, which means that it has more surgical modules attached to it. After that, we're going to go to the Role 3, which is the first unit that can offer definitive surgical care. It's still in the combat zone, but this one is a tactical field hospital. It's the first time that we talk about hospitals that have almost full medical capabilities. Like an example here is the fact that at Role 3 is the first part where we will find a plastic surgeon, a neurosurgeon, things that require more specialized type of support. The Role 4 is outside the combat zone. It's a military or civilian hospital, in most cases the closest one to the tactical field. It has full medical capabilities, and it's the first place where we can start to say about full physical and psychological recovery capabilities. This is the place where prosthetics are added. It's the first part of the reintegration of the worst wounds seen in combat. My conclusions are the fact that continuous adaptation of military medical doctrine is essential for enhancing operational effectiveness and prevent the fighting force in modern warfare. Here we can talk about the fact that having the world's best medical care support, we will talk about enhancing soldier morale by instilling a sense of security using this information. Because this creates a dual effect, improving both medical efficacy and psychological resilience, and plays a vital role in sustaining operational readiness and effectiveness across Allied forces. More so, I will show you a protocols in action video, which I took. I was an observer to a NATO multinational medical exercise in my country, and here we will see in action implemented all the protocols that I've talked about to see their effectiveness. Ladies and gentlemen, thank you for your attention. This is a QR code of my article. And thank you for giving me the opportunity to be here in front of you and having the patience to listen to me.